Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 489 of our pharmacotherapy series, which majors in ischemic and hemorrhagic stroke. The first case reads: SPC is a 58-year-old man who is sitting at home watching television with his wife when he develops confusion, nausea, severe headache, and right arm weakness. His wife immediately calls for an ambulance, and by the time paramedics arrive, SPC is slumped in his chair and unresponsive. Significant past medical history includes poorly controlled hypertension, atrial fibrillation, and osteoarthritis. He takes lisinopril 10 mg by mouth daily, warfarin 4 mg by mouth daily, and acetaminophen 1000 mg by mouth 3 times daily for these conditions. Upon presentation to the emergency department, his blood pressure is 184 systolic, 114 diastolic. ACT scan shows an intracerebral hemorrhage. Key electrolyte concentrations, coagulation studies, and blood counts are within normal limits, except for an INR of 4.8 and a blood glucose level of 194 mg per deciliter. SPC's neurologic symptoms and the appearance of blood on his CT scan are consistent with a diagnosis of intracerebral hemorrhage, abbreviated as ICH. So my first question to you reads: what risk factors for spontaneous intracerebral hemorrhage does SPC have? SPC's uncontrolled hypertension and his use of warfarin has increased his risk of intracerebral hemorrhage. Specifically, use of warfarin increases the risk of intracerebral hemorrhage by 2 to 5 times depending on the degree of anticoagulation. Patients, such as SPC, who are taking warfarin before intracerebral hemorrhage and present with an INR greater than 3 are at greater risk for developing larger hematomas, which are associated with worse outcomes, compared to those taking warfarin and presenting with a lower INR. Patients taking oral anticoagulants are also at greater risk of death after intracerebral hemorrhage versus those not taking anticoagulants. Other drugs that may increase the risk of intracerebral hemorrhage include target-specific oral anticoagulants, such as dabigatran, rivaroxaban, apixaban, and edoxaban, heparin, low molecular weight heparins, fondaparinux, and other parenteral anticoagulants, aspirin and other antiplatelet agents, selective serotonin reuptake inhibitors, and sympathomimetics, such as amphetamines, phenylpropanolamine, cocaine, and caffeine-containing medications. Additional risk factors for non-traumatic intracerebral hemorrhage include advanced age, history of stroke, diabetes, smoking, excessive alcohol consumption, African American ethnicity, and low cholesterol levels, especially in the absence of HMG coenzyme A reductase inhibitor use. Genetic predisposition does not play a role in most hemorrhagic strokes except for those caused by arteriovenous malformations. The next question reads, what are the key principles of therapy in patients presenting with spontaneous intracerebral hemorrhage? Initial management of spontaneous intracerebral hemorrhage involves the following. 1. Preventing hematoma expansion. And 2. Preventing and managing elevated intracranial pressure. To minimize hematoma expansion, anticoagulants should be reversed immediately in patients such as SPC, who present with drug-induced coagulopathies, and blood pressure should be carefully managed. Methods for preventing and managing elevated increased intracranial pressure include avoiding hypertonic fluids as well as medical and surgical methods. Ancillary therapies including treatment of fever and avoiding hypoglycemia and hyperglycemia are also suggested. The next question reads, what pharmacotherapy should be initiated to reverse SPC's anticoagulant-induced coagulopathy? Up to 20% of patients with intracerebral hemorrhage present with a drug-induced coagulopathy, like SPC, because hematoma growth within the first 24 hours of intracerebral hemorrhage is directly associated with worse outcomes, and reversal of warfarin-induced coagulopathies within 4 hours of intracerebral hemorrhage has been shown to limit hematoma expansion. It is important to reverse coagulopathies in a timely manner. All anticoagulant and antiplatelet medications should be immediately discontinued, and agents should be administered to remove the anticoagulant medication from the body and reverse its effect. Although SPC was using warfarin for prevention of ischemic stroke in the setting of atrial fibrillation, because of his acute intracerebral hemorrhage, the benefit of reversing the warfarin in order to improve neurologic outcome greatly outweighs the short-term risk of ischemic stroke resulting from anticoagulant reversal. If a patient has taken an oral anticoagulant within the last 2 hours, activated charcoal may be considered to prevent absorption. However, it is important to ensure the patient can tolerate enteral administration. Historically, fresh frozen plasma, abbreviated as FFP, has been used to reverse warfarin-induced coagulopathies in patients such as SPC. However, prothrombin complex concentrates, abbreviated as PCCs, have recently become the recommended agents to rapidly reverse anticoagulation because of warfarin. Fresh frozen plasma contains all the clotting factors depleted by warfarin, but can take several hours to thaw and administer, and may be associated with pulmonary complications and edema because of the volume required. In contrast, prothrombin complex concentrates may reverse the INR within minutes because they can be administered more rapidly. Additionally, prothrombin complex concentrates are associated with a lower risk of volume overload and pose a lower risk of infection than fresh frozen plasma. Use of prothrombin complex concentrates in this setting has been shown to more effectively limit hematoma expansion compared to fresh frozen plasma, but improvement in clinical outcomes has not been demonstrated to date. 3-factor prothrombin complex concentrates contain factors 2, 9, and 10, while 4-factor prothrombin complex concentrates also includes factor 7. Prothrombin complex concentrate availability may be limited by institutional policies, in part because of the high cost of treatment relative to other therapeutic options. Because the effect of prothrombin complex concentrate and fresh frozen plasma is short-lived, patients with warfarin-induced coagulopathy should concomitantly receive 10 mg of IV vitamin K, that is phytonadione, by slow infusion. Newer oral anticoagulants indicated for non-valvular atrial fibrillation include dabigatran, rivaroxaban, apixaban, and edoxaban. Although data regarding management of intracerebral hemorrhage patients receiving these agents are limited, some experts suggest using a prothrombin complex concentrate product. Idarucizumab is a monoclonal antibody that can be used to reverse dabigatran. Agents for reversal of other target-specific anticoagulants are under study. Importantly, dabigatran can be removed through hemodialysis. As with warfarin-induced coagulopathies, reversal agents should be administered promptly and activated charcoal should be considered. Other drug-induced intracerebral hemorrhages may occur in patients receiving heparin, low molecular weight heparins, the parenteral factor Xa inhibitor fondaparinux, and antiplatelet agents such as aspirin and clopidogrel. Protamine sulfate may be used for the reversal of heparin and low molecular weight heparin, while fondaparinux activity may be antagonized with prothrombin complex concentrates. No intervention has been shown to be clearly beneficial in patients experiencing intracerebral hemorrhage and taking antiplatelet agents, although studies are ongoing. To reverse his warfarin-induced coagulopathy, SPC should receive a weight-based dose of a prothrombin complex concentrate product and 10 mg IV vitamin K by slow IV infusion. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 490.